Hello everyone. Thank you for giving us the opportunity to present here today. I'm Tomomi Takeshima and she's Chise. We are working for Milliman Incorporated in Tokyo, Japan. Our presentation is titled Effects of Improved Health Indices on the Quality of Life and Healthcare Costs. Globally, the healthcare industry is developing applications using data and IT to manage various health indices such as weight, calorie intake, blood pressure, sleep, and blood glucose levels. Japan is no exception. Dr. Hiroaki Kato advocates Healthcare 4.0 in his book, Digital Health Trend 2022, which consists of 3 characteristics: diversification, personalization, and subjectivization. Diversification refers to the expansion of healthcare delivery from physicians alone to outside the healthcare system, such as through applications and smart cities. Personalization refers to tailoring healthcare to each individual based on their own data. Subjectivization means that patients have their own health data and are responsible for improving their own health. One of the key drivers of Healthcare 4.0 is digital health applications. So are you currently using any such digital healthcare applications? Actually, I use some applications, and my favorite one is the application to track my sleep. To track my sleep and analysis that my sleep state. When I go to bed, I wear this Apple Watch to track my sleep state, and I can confirm several things, including when I actually fell asleep and how well I rested through this application. I can also understand the relationship between the actions I take before going to sleep and the quality of my sleep. But actually, I'm not sure that actual effectiveness on my health or on my healthcare cost. But I am satisfied with my better understanding of my sleep. So there's no problem when digital health applications are sold to individuals like me. But there is a major obstacle when they are sold B2B2C through corporate health plans. The effectiveness of the applications is not known even to the developers of the applications. Decisions by companies and health insurance associations are based on whether the effectiveness of the application is reasonable compared to the cost of the price. However, application developers are often startups, have no observational data, and would need large amounts of money and long periods of time to generate such data through clinical trials. This obstacle is the main reason why digital health applications have not yet taken off. Even when the effectiveness of digital healthcare applications can be demonstrated in some way, in many cases, the measure of effectiveness is too medical to be used for decision-making by companies and health plans. For example, suppose an application that helps people self-manage diabetes lowers HbA1c levels by an average of 1%. Yes, the application seems to work well, but without knowing how much it improves the user's quality of life and how much it reduces healthcare costs, the company or health plan cannot select the application. Or if there are two applications, one is that lowers HbA1c by an average of 1%, and another is that gives smokers a 50% chance of successfully quitting smoking smoking costs the same price. They cannot decide which one to choose without knowing the impact on quality of life and medical costs. So our study that we will present today shows for each of the different types of digital health applications, if they can improve scientific indicators by a certain amount, how much they affect the quality of life and healthcare costs. The results of our research on what types of applications exist in Japan and how scientifically effective they are will not be included in today's slides. Our study is a rewrite of the language of science into the language of business. We use real-world data provided by DeSC at DeSC Healthcare to conduct this study. DeSC Healthcare is a leading real-world data vendor in Japan. DeSC Healthcare was established by DNA Incorporated and Sumitomo Corporation. DNA Incorporated is a Japanese internet-related company mainly engaged in the development and distribution of games for smartphones, as well as e-commerce services. Sumitomo Corporation is a major Japanese general trading company. The database of DeSC Healthcare includes 8.3 million insureds of employee health insurance, national health insurance, and healthcare system for age 75 years and more. The data consists of the insurance coverage data, claims data, health checkup data, EQ5D5L, which is a standardized measurement tool used to evaluate health-related quality of life, work productivity and activity impairment, which is a questionnaire to measure productivity loss, and health literacy.
Okay, from this part, I'm going to talk about how to analyze the data. Don't worry, it's not so difficult, and I'm sorry for someone, it's not so difficult. It's actually very easy. And the figure shows on the slide the selection of an analytic population. In DeSC healthcare dataset, there were 488,389 people who were covered by employee health insurance and had annual health examination data. On the other hand, this one, insured people who having QOL was 49,671 people. So the number of people in both categories was, people who have who were in the database of DeSC and having check analysis, healthcare analysis, and having QOL was 34,154, which we defined it as analytic population for this study. The Japanese government has specified and standardized a large number of items in the Japanese annual health checkup data, such as these one. And the first 7 items from BMI to this one, the BMI, systolic blood pressure, triglyceride, HDL cholesterol, hemoglobin, HbA1c, hemoglobin estimated, eGFR is obtained from the blood test So all Japanese people take blood test and they have these data at the healthcare checkup test, checkup test. On the other hand, from the smoking to sleeping status, these data is taken by the questionnaire, not the survey. So the smoking status means one is smoker and 0 is non-smoker. And P, physical exercise status, is who does physical exercise more than 30 minutes, more than 2 days per week. I'm surprised, it's too hard for me. And the quick eater is 1 if you think you're a quick eater, and 0 is otherwise. It depends on what you think. And the frequent drink is 1 for person who drink alcoholic every day, and 0 is otherwise. And rest, sleeping status, is 1 if we are well rested with sleep, and 0 is otherwise. So I have to mention some of these data are based on the survey, I mean the blood test, and some of them are just based on just questionnaire. And this is a part of regression model. As I said at first, it's very easy. In this slide, we have created 2 very simple types of linear regression models. CUV on this one is checkup values, I mean the 13 checkup values on the previous slide. So in the first type of the model, this one, the dependent variable is PMPM, which is the medical cost per member per month. The per month doesn't mean per patient. It's just insured people. So it doesn't depend on their patient or not. And the explanatory variables are female flag and age, and the one of the 13 checkup values. And QOL, from the second formula, the only difference is these dependent variable. On this one, the dependent variable is QOL, but the model is totally same as the first one. As shown in this formula, in each type of the models, beta 3 represents the change in PMPM or QOL when checkup values changed by +1, I mean the +1. For example, BMI changes from 24 to 25, or the sleeping status is changed from 0 to 1. It's the same +1 for this study. The meaning that changed by +1 depends on what each checkup value means, as I mentioned. For example, the checkup value is HbA1c. The first equation shows how much 1% difference in HbA1c results in the PMPM. And the checkup value, if the checkup value is smoking status, the second equation shows the difference in QOL between non-smoker and smoker. So please remind here, a beta 3 does not suggest a change in PMPM or QOL for a given person checkup values change. But it only means the average difference in PMPM or QOL among persons with different checkup values. Because this formula, we use just gender and age for the confounders. So it's not useful as RCT, it's randomized control test because of the lack of confounders. And yeah, this is the result. This table shows the beta 3 defined on the previous slide. The checkup value columns show the 13 checkup values presented on the 2 previous slides. The QOL columns shows the beta 3, the QOL model for each checkup values. And the PMPM, this column, sorry, it's opposite, but the QOL is that and PMPM is that. And the last column here show the year-based monetary equivalent of the combined effect of QOL and PMPM. The monetary equivalent of QOL is QOL multiplied by 5 million yen, which is ICE threshold for health technology to be cost-effectiveness in cost-effective analysis by the Japanese government. ICE is the ratio of the incremental cost divided by incremental effectiveness. Thus, 5 million yen represents the amount that an average person living in Japan would be willing to pay for one increase in QOL. Through these steps, we can calculate the number of QOL and PMPM for both of it, and make sure that the plus or minus, I mean the red or black one in the last column is consistent with common sense. Common sense, in other words, for example, the sign of BMI here is negative. This indicates the value on an increase of 1 in BMI. Thus, value of application that decrease BMI will be positive. The sign of sleeping status here is positive. Sleeping status is 1 if you are well rested with sleep and 0 otherwise. Thus, the value of application that improves sleep equality will be positive. And interestingly, the drinking status, the last column of drinking status is here, positive. This is probably not the alcoholic increasing QOL or lowering PMPM. I know for someone it can work, but rather of healthy people being able to drink alcoholic every day. And QOL smoking status is negative here. The QOL of the smoking status is positive, is reasonable, but at the same time, the the PMPM is also negative. This means medical costs of smokers are lower than the non-smokers after the demographic adjustment, which seems strange, but we do not know the exact answer about that. And the last column on the previous slide showed the value of 1 increase in each of the 13 checkout values. However, as I mentioned, an increase of 1 in BMI and an increase of 1 in HbA1c are completely different for the same one. So this slide showed the value per target, the value per insured person. If the hypothetical distal health application changes the average value of the hypothetical target by some hypothetical value. For example, if an application exists on BMI here, and the application targets people with BMI greater than 25, which is 9.7% of the total insurance population on this data set, and the application targets to lose their BMI by an average of 2.5. The value of an application is 3,554 yen per target per person. And of course, there are just only 9.7% of the people who have more than 25 BMI. So we have to adjust, and after adjusting, the 345 yen per insured per person year is calculated. And finally, I have to mention about the caveat. There are a lot of caveats in this study. First, this study may not capture causality, but correctly. As already discussed, drinking status, the greater quality of life and lower healthcare costs for daily drinkers may be causal because only healthy people can drink dairy. I hope so. Second, as already discussed as the regression model, the results show the difference between two states, not the difference when one person moves from one state to another. And third, the results are not partial derivative values. So to speak, focusing only one checkup values. For example, if a person has lost weight to normal weight by means of weight control application, he or she may be exercise or more drink or less as a means of doing so. So the value of those changes are also included in the value of the weight control application. Fourth, as I mentioned, we use just gender and sex for gender and age for confounders. So we have to consider more. And fifth, we use the regression model. So some of the checkup values, it can't be suitable for the regression model. But this is just the first step, and we want to study the most simple at first. So we use just linear. And sixth, this study assumes that the effect of application lasts forever. So, for example, rebounding the weight control is not taken into account. And seventh, the targets goal in the previous slide are hypothetical values, and we did not check whether such application exists or in reality. And eighth, what matters for decision making is ROI, return of investment. But we just focus on the return, and we can't focus on the investment. So we do not know if its ROI is significant for the applications on our study. And this is all of our presentation. Thank you for listening.
We've got time for a few questions. There's one that's come in on the app. Someone who's challenging the elevated health risks, not of the drinking one. I think that's what we're talking about. But why is there an elevated health risk associated with being a quick eater or skipping breakfast? So I think one of the health risks that were up there was if it was a quick eating. Mm-hmm. Or skipping breakfast was seen as elevated health risk. So the question is why is that considered a risk, a high risk?
Eating quick eating is kind of health risk, I think, and that you asked why we selected these 13 indices, right? Yeah. So. Eating habit is one of the target to improve using these kind of applications, and so quick eating is one of the such factors. So we selected to observe the eating habit. So we included this factor, but we just kind of made. We just assumed the application, but I'm not sure. We are not sure that such applications are available. But in my understanding, some applications include such eating habit. So that's why we included this factor.
I think everyone will be eating a bit slower at dinner time now, anyway. Any questions from the floor? We're going to open up for a panel discussion shortly, but was there any other questions on this specific presentation? Yep, we've got one here.
I would have two questions, and sorry for missing the first part. So it seems like a discrete model, and I would recommend as one of the next steps to build a dynamic model, which is kind of continuous. So not moving from state to state, but the gradients and the slope of moving, as you may wish. And the second question actually is, there's a lot of recommendations on social media, I would say, so I don't know to what extent that is true, that intermittent fasting is recommended, so beneficial for your health, while the app, in your case, suggests skipping breakfast is not good. So can you comment on that?
Okay. So that the first question, so that this study is kind of first step to evaluate these kind of applications, and so as you said, and you mentioned kind of dynamic model, so to incorporate various, so to change the stage to change the stage. So I mean that first step, and the person did something, and to go to the next step or not or something. So such complex model is probably good to to evaluate these kind of applications. So we have to study to which model is actually good to evaluate such applications. But we want to say this, even though simple model can evaluate these kind of applications. So this is our opinion on the presentation. And for the second question, so you mean that kind of effect of fasting or so? Personally, I'm interested in which is better, so to skip breakfast or to eat breakfast, or to kind of to continue, so how to say it, so kind of routine dietary habits. So I'm just interested in.
Yeah, it's very interesting point. Actually, we're in Japan, it's not so popular, the fasting. Maybe just it's popular for the young lady, just for young ladies. So yeah, it's thank you for the point, and we have to study advanced. Okay.
We might just go, I know I've got another question there, but we might just actually go to the group Q&A. So I might just thank the team for the presentation. And also have the other panel members coming up.